Good afternoon. I'm Dr. Del Cura. Unfortunately, and despite my efforts, the problems with my flights have not allowed me to be there in the Congress, in the National Congress of Radiology in Hurghada. It's a pity, but well, I've tried to do my best and send the recording of the communication, of this presentation, to be at least online, virtually instead of in person. My presentation, excuse me. Is going to treat the percutaneous technique and treatments we can use for treatment of liver metastasis. In the next minutes, well, these are my conflicts of interest. In the next minutes, I'm going to try to describe the different procedures used in the treatment of liver metastasis. I'm not going to discuss the procedures using for diagnosis, so I'm not going to discuss biopsy. I will explain which are the different devices used, and especially the current state of the art of every technique, and especially the strengths and problems we can face when we use every technique. And finally, I will discuss indications and current trends in the use of these devices to treat the patients with liver metastasis. The first device I'm going to discuss are markers, especially fiducial markers. Well, fiducial markers are used especially in two of the techniques we use to treat the liver metastasis. And these techniques are the adjuvant and neoadjuvant chemotherapy. Both techniques are frequently used in the treatment, especially in the colorectal liver metastasis. Adjuvant therapy is used to improve patient survival after resection, and is very frequently associated to surgery. And neoadjuvant is a different concept in which in certain patients in which surgery is not possible, using chemotherapy can, in some cases, downstage the tumors and make the surgery possible. Well, the problem with adjuvant and neoadjuvant therapy, especially for neoadjuvant therapy, is that frequently after chemotherapy, the metastasis sometimes disappear. It's not infrequent. I've seen this in person sometimes, that when the surgeon is going to resect a metastasis after chemotherapy, the surgeon can't find the metastasis anymore, because the metastasis sometimes disappear completely, but some cells remains, and in the future probably these metastases will regrow and reappear. So we need to make possible for the surgeon to resect these lesions. And well, in these cases, this especially happens for small lesions. We have a possibility that is placing a marker that can be seen during surgery or during the ablation, also inside the lesions. If you have, in this case, for example, we have these two small metastases in the liver, and using a needle, we can left a small marker, a small metallic marker inside the lesion to guide that can be seen, for example, with using ultrasound during surgery. We can place it in the lesion to be seen for the surgeon when he is going to resect the lesion, and can resect the area of the lesion. So, and the same is for ablation. This is the same. In this case, you can see the marker here that after chemotherapy can signal the place of the lesion to the surgery. The fiducial markers are placed in two ways. First, we can use it in the middle of the lesion that are intended to use as a guide for surgery or for ablation, but we can also place them for stereotactic radiotherapy In this case, we usually place a couple or 3 small markers surrounding the lesion to guide the radiotherapy during this kind of procedure. This is another example. You can see here a very small lesion that the patient was not able to go to the surgical theater. So, in fact, we were going to perform an ablation, and the lesion was very small. The oncologist decided to treat the patient with chemotherapy before the ablation, and of course, in this case, we placed a fiducial marker inside the lesion, the small lesion, and after the treatment, you can see that the fiducial marker is in the middle of the ablated volume. Well, the second technique I'm going to discuss is the ablation. The ablation has evolved along the last years, changing from the only one technique to several now. The first technique we used for ablation was the radiofrequency ablation. Radiofrequency ablation is in fact using or placing the patient inside an electric field, an electric circuit, in which we use alternating current, but with a different frequency than the domestic frequency is lower. In this case, this alternating current creates around the electrode, the tip of the electrode creates an alternating current, and this alternating current acts over the electrons around the needle, and these electrons move to and fro, causing friction in the tissues, and this friction creates heat. And the result is that when we place the needle or the electrode inside the tumor we are going to treat, we create heat. That this heat makes, with time, causes the denaturation of proteins, and finally a coagulative necrosis around the needle and the cells around this area. Well, we have several types of devices to perform radiofrequency. We have different shapes of electrodes to perform this technique. Some of them are like umbrella, are detachable, are deployed, can be deployed, making a wide area of ablation. Some of them are straight. The most important thing to remember is that every of these electrodes have different shapes of ablated bone. This is very important to know to make the most of the technique, or to adapt the technique to the size of the shape of the nodule we are going to treat. Another thing is important to know is that we have some problems with radiofrequency. That is that the radiofrequency is affected by the heat sink effect. That is that around the vessels, when there is a vessel around the area, the treated area, these vessels act as a cooling, creating an area of inefficient ablation around these vessels. So the vessels affect the volume of ablation. Another problem is that we need the grounding paths to close the circuit in all the patients. Sometimes we can have problems with the pace markers. The radiofrequency interferes the pace markers. So sometimes we need to disconnect these pace markers before during the ablations. Well, the hydrodissection that is very frequently used in these techniques is not possible with saline, but we can use the 5% dextrose instead. The second most popular technique for ablation is microwave. Microwave uses, instead of an electrode, uses an antenna. An antenna creates an electromagnetic field around it that acts over the ionic molecules of, especially the molecules of water, and creates a movement of these molecules around the area of where the antenna is placed, and this movement creates a very high temperature. In fact, the action is quite similar to the action of radiofrequency on the cell. The difference is that no grounding paths are required, only the antenna, the needle that is an antenna. And the most important thing is that it's not affected by tissue impedance, because the microwave, as they are electromagnetic waves, crosses freely through tissue, and they don't need at all. It is not affected by them. So the volume of ablation is more predictable because it doesn't depend on the characteristic of the impedance of the tissue, and theoretically is not affected by heat sink effect. The microwave allow reaching higher temperatures, and well, this is an example. We have seen this a recent case of ours. You can see a metastasis just in the segment 5 in the liver, just close to the portal vein, and we can see here the antenna placed just inside in the metastasis that is here. And well, this is from other point of view. You can see the antenna here and the bubbles around the tip of the microwave of the antenna, and this is the result. You can see that all the lesion has been covered, and a safety margin also has been ablated. Well, the microwave has a dual action. It's very important to know. The inner part of the action that is caused by conduction is fast, is made by direct action of microwaves, is not affected by vessels, but the outer part of it, if we maintain the temperature, the action of the microwaves for more time, is made by convention of the heat, so it is slower, and in this case, yes, heat sink effect can happen. So this is an example of the heat sink effect in case of microwave. You can see an example after the treatment of the patient. You can see the contrast enhanced ultrasound in this case, in which you can see here two vessels creating an area of inefficient ablation around these vessels. Another case, you can see here a lesion. This is in a hepatocellular carcinoma. Here is a vessel around the nodule, and after the treatment, you can see here and here the area around the vessel that has not been completely treated, so efficiently treated as the rest of the tumor. This is very important to remember when you use microwave to treat lesions. Also, it's important that in a similar way of radiofrequency, the devices used has not the similar efficacy. This is difficult to find. Articles comparing several devices, but this is one of the few that more recent, despite being old, comparing several devices. You can see that the efficiency of the volume of ablation of the different devices in this case was completely different. Some of the devices studied here are no longer used, but you can see that it's not the same using one device or another one from another company. This is important to know and to check your results. Well, comparing radiofrequency and microwave allow reaching more temperature, allow a more predictable ablation, especially in healthy liver, because it has also less heat sink effect and greater diameter of ablation. So I usually use microwave for treatment of metastasis in healthy liver. The radiofrequency has a more extensive experience and it's cheaper, but well, it's also a very good technique. The problems of ablation, you should remember that sometimes around the lesion, around the metastasis, there are some small micrometastases around them. So when you perform ablation, you have to be sure that you cover enough healthy tissue around the lesion to be sure that you have included these small areas of small metastasis, because the recurrence can happen if you don't treat enough tissue around the lesion. Another problem is that the bigger the lesion, the bigger the size of the lesion, the most possible the complications appear. Also, having performing ablation around any structures, for example, bowel or similar, can cause thermic damage on these structures, and this is important to plan before performing the ablation to avoid these complications. The best, the most efficacious effects these techniques are are obtained especially in lesions below 3 centimeters diameter. Well, there are just a few comments about another techniques that can be used. The first one is cryoablation, that uses a probe with a gas expansion freezing system to freeze the lesion. I use it in liver, but this is an example that we have used recently in the lung, that you can see the areas of hypodensity around because the ice ball around the cryoprobes. And also the irreversible electroporation that uses short electrical pulses to damage cells, and that has the advantage of respecting vessels and ducts. However, this technique has still low experience and is technically complex and is not very frequently used. So if we compare techniques, the most used are microwave and radiofrequency ablation. The cost of both them are relatively affordable, and the microwave has the advantage of the short time of required to perform the procedure, and the higher predictability. And well, cryoablation appears as a challenger in the near future, probably. What about results and indication? First of all, the most important benefits of these techniques are the lower number of complications compared with surgery. Major complications are below about 4%, and mortality is exceptional. In general, the overall survival after this treatment in patients with unresectable disease has been described that are about 50% in 3 years, more than 30% in 5 years. But in potential resectable disease, the survival has been described, the 5-year survival has been described to be about 50%. This is important because this is, in this last case, there is the possibility of competing with surgery. And what about comparing surgery and ablation? Well, when the comparison is difficult, because in most of the published cases, in the most serious, the ablation was performed only in patients that was not considered for surgery because of several reasons. So in general, in the meta-analysis, in the recent meta-analysis, the techniques of ablation has been described as having lower complication rates, and also but an increase lower disease-free and overall survival. But in this meta-analysis, the authors explained that due to the difference in the evidence between both the treatments, there are strong selection biases, and there was a need for propensity matching studies. But we have now propensity matching studies, and we have 3, in fact. And these propensity matching studies, in which they compared similar groups for surgery and for ablation, the results are quite similar. That after adjusting for these factors, no significant difference was between surgery and ablation. So, in fact, ablation appears as a possible competitor because of the lower ratio of complication, a strong competitor in the near future for surgery. Up to date, in fact, the indication, the official indication for ablation in metastasis of colorectal carcinoma are follow the statements of the experts of 2015. It is considered that the ablation is a treatment of choice in patients with unresectable and or in patient who refuse surgery, to allow surgery after portal vein embolization, and also in unresectable as a potential future indication in solitary tumors below 3 centimeters in diameter. Well, but there are other possibilities, and one of these is the combination of ablation and surgery. We can use ablation to perform surgery in patients that were, if we use only surgery, were not able to be potential candidates for surgery. For example, this is a patient in which the patient had several metastases in the left lobe, not shown here, but he had a couple of metastases here. Well, in this case, we decided to treat, first of all, these two metastases. This is, you can see here in this ultrasound, the antenna and the bubbles. And after treatment, the patient was the left lobe of the patient was resected. So using this kind of combined treatment, you can see here 2 years after the ablation and surgery that the patient was perfectly well without sign of residual disease. Here you have also another patient with several metastases. The patient had several more in the right lobe of the liver, not shown here. You can see here one, another, and another. In this case, the patient was treated with ablation in the left liver. In fact, 3 lesions were treated with ablation, and the right lobe was resected. Here you can see the signs of ablation. With these combined treatments, the patient could survive for many years after treatment. And this is the last case, and this is a more complex case that shows us the possibilities of the technique. This is a patient with multiple metastases. You can see here the patient had only the left lobe was relatively respected because he had only 1 metastasis, and there was also this another metastasis in the segment 1. In this patient, we performed first neoadjuvant chemotherapy. For this, we perform first a placement of fiducial markers in the lesion we're going to treat with radiofrequency. After this, we perform radiofrequency ablation in the lesions in the left lobe. And after this, because the left lobe was so small that was not enough to permit an adequate hepatic reserve after treatment, we perform a right portal embolization. This right portal embolization allows the left lobe of the liver to hypertrophy because of the embolization, and we follow the patient after this embolization until we saw this. You can see here the scar of the ablation of one of the lesions. After the patient, the left lobe hypertrophy enough to have to guarantee enough hepatic reserve, we perform the surgeons perform the right lobe hepatic resection. During the surgery, we perform also an ablation of the lesion of the segment 1, and this is the final result. The patient, after this, incredibly survived for more than 10 years, despite having an extensive disease. Well, as a summary, remember that we have a wide range of percutaneous tools for treatment of liver metastasis, that we have fiducial markers that should be used always in patients that are going to be submitted to adjuvant or neoadjuvant therapy, that the ablation techniques are excellent techniques that are probably similar in result as surgery, and the techniques also we can use also these techniques, the ablation techniques, combined with surgery to expand the boundaries of the possibilities of treatment of the liver metastasis. And this is my hospital, my mail, if you want to have some comments to me, as I'm not going to be in person. Thank you very much, and have a happy Congress.